from. And we're going to speak about the endovascular revolution. And what we have been listening yesterday and today is part of that revolution. This early session on thoracic stent grafts is showing important improvements in this technology. So when we look back in the history of endoluminal treatments, there are important landmarks that we can mark. 3,000 years BC, the Egyptians performed bladder catheterization using metal pipes. And that can be probably the original procedure of utilization of endoluminal techniques. Schonholz conducts the first cardiac catheterization of a horse using a brass pipe, a glass tube, and the trachea of a goose in 1711. Some of the things that are better known are more recent, like the Werner Forsman situation, where he was very curious about the catheterization of the heart, and he put himself a catheter in his left arm and pushed his catheter further, and then he walked to the Department of Radiology and asked for a chest X-ray to prove that that catheter was actually in the right atrium. He was, the people from the hospital were not very happy with him, and because he was taking some important risk, but interesting enough, years later, in 1956, he, together with Kurnar and Richards, were recognized with a Nobel Prize for those innovations. The other important landmark, no doubt, was in 1958 by Mason Sons, who was the first doing coronary angiograms. And then 1953, we have Sven Seldinger, who is considered one of the fathers of these minimal invasive techniques, because he came with the concept of the percutaneous introduction of a catheter inside the lumen of a vessel. And of course, this can be used not only for vessel navigation, arterial veins, but we can use, and actually we use this technology in our everyday practice to introduce catheters in different compartments. 1964, an important contribution done by Charles Dotter, an interventional radiologist, who published an important paper on transluminal treatment of atherosclerotic obstructions. That paper is remarkable if you have the chance to review it. He speaks about very basic ways to treat patients with obstructive arterial disease, but he also mentioned things that will come in the future, like stents and stent grafts. So it's an interesting paper to go and review. And he used to say that it's a gross oversimplification, of course, but it means to me that if a plumber can do it to pipes, we can do it to blood vessels. An interventional cardiologist from Switzerland, Andreas Grunzig, came with the idea of introducing a balloon that can be inflated from a different sidearm axis to perform balloon angioplasty. And this was very interesting. He developed this technique in Europe, and we, in America, we invite Andreas to come, and he came to Emory in Atlanta. Unfortunately, when we bring these people to America, we not only give them all the infrastructure to do things, but we also pay them well. So he got a plane, and unfortunately he died during an accident while he was in his own plane. So another person that came after him, and because he listens to a lecture by Andreas early on, and he learns from Andrea that despite the good results of balloon angioplasty, there is an important number of patients that have what we call recoil. So the vessel comes down after balloon angioplasty. So this doctor He was a radiologist intervention. He is an interventional radiologist originally from Argentina, working in Texas, in San Antonio, Texas. He comes with the concept of a stent. In this case, it's a balloon expandable stent, so it's a metallic scaffold that is deployed with the inflation of a balloon that maintains the vessel open after balloon angioplasty. And after Julio, one other surgeon from Argentina as well, Juan Parodi, who did his residency here in US at the Cleveland Clinic, he got an idea when he was a resident in 1976 of a new way to treat patients with abdominal aortic aneurysms. And the reason he wanted to come with this idea is because this is a patient population that is very sick, and by doing a minimal invasive technique, no doubt these patients can benefit. I was lucky enough to meet Juan in 1989. We were both working in Buenos Aires, Argentina, and in that first encounter, Juan shared with me his project. It really sounded very, very funny and very difficult for me at least as an interventional radiologist to achieve, because he was talking about placing a large device, 25, 27 French through the groin to fix aneurysms. At that time, we were already doing interventional procedures, both diagnostic and therapeutic procedures, to 5, 6, and 7 French sheath. And actually, because I trained in France, I was inspired by the pioneer work of Jacques Theron in the field of carotid interventions. So when Juan told me about his AAA project, I responded by telling him that I was doing carotid interventions. Of course, as a surgeon, and knowing the risk of distal embolization, he immediately asked me to stop with that particular technique. And he said to me that if I promised him that I would stop carotid interventions, he would invite me to join his team for stent graft of abdominal aortic aneurysms. So after a little research that I did myself, I learned that Juan was a serious person, and I decided to put a hold in my project of carotid interventions. And this is the type of patient population that Juan was thinking. These are very sick patients, and the idea was to create a technique for this particular problem. So he tried, again, very early on, different prototypes. He created self-expandable box with a zigzag configuration covered with nylon, silastic bag with cylindrical lumen. All this design failed mainly because everything was migrating distally. So he didn't know how to replace the suture that the surgeons do when they do surgery with something endovascular. But in 1988, Juan attended a meeting in Washington. The TCT meeting at that time was happening at the Omni Hotel, with only 200 registrants and 12 faculty. Just for you to have an idea, nowadays that meeting holds 15,000 people. So during that meeting, Juan listens to the lecture that Julio Palmas is giving about stents for iliac artery occlusion. And when he sees the balloon expandable stent, he realized that that was the tool that he needed to combine with a piece of graft. And that combination could replace the suture done surgically. And he put together this device that you can see here, where the stent is sutured to a piece of thin wall Dacron. And all this is packed together with a balloon. At the time that those were the balloons that were used for aortic valvuloplasty, everything placed in a sheath that was 25 to 27 French, and they created an animal model where they replaced the infrarenal aorta of a dog, creating an aneurysm that then was treated with this technique. And this is the observation of the macroscopic pathology specimen showing the integration of the stent covered by endothelium that will end up preventing migration of this device once it's implanted. And this is the histologic confirmation of the same thing. So the technique was conceived in a way that from a groin axis, from the femoral artery, the device was going to be travel to the neck, below the renal arteries, and once in position, and when you recognize where the renal arteries are, you inflate the balloon, you deploy the stent, and therefore you create a tube that reinforces the wall of the aorta and prevents rupture. And this was September 7, 1990, where the first case was done in Buenos Aires, Argentina, at the Cardiovascular Institute with Juan and Julio that traveled for the occasion. That was the first time that this type of surgery, which is very invasive, which can be very bad for patients that are very sick, was replaced for this type of access, minimally invasive technique through a small cut down in the groin. Very important landmark. And nowadays, we are moving to something even less invasive, which is what you see here. Percutaneous technique created with sutures that we can deploy before we introduce the large devices. And these patients now are doing really well because this is really minimal invasive interventions. In these two pictures, you see two patients that were treated that day on September 1990. The one on the left was the guy that had the first AAA treated by endovascular route. He's having dinner, sitting. He had you see the dressing in the groin. The other guy had conventional surgery the same day. He's still intubated in the intensive unit care. So we learned rapidly that we can treat not only aneurysms, but dissections, vascular trauma, and occlusive disease with this technology. And these are some of the examples of treatment of patients that we were doing around different places. Again, we were only treating high-risk patients at the time. We also learned that the morphology of the aneurysms vary tremendously, so with the growth of the aneurysm. So our initial design of aortic tubing was only be able to be applied for a limited number of patients. That's why in 1991, soon after we started doing clinical cases in Argentina, we moved to an aorto uni-iliac configuration, as you can see, with occlusion of the contralateral iliac artery with detachable balloons and a fem-fem bypass. And this is the image of such a procedure. In October of 1992, we were invited to go to Europe to do the first treatment of a patient with an abdominal aortic aneurysm by two cardiologists. And here are images of that procedure where you see Claude Mial, who was one of the surgeons down there, with Claude Amicaville, who recently passed. Together with Juan and our engineer, we did that first case. And Claude Mial was very interested in this technique, and he immediately got attached to this technique, and he came after a couple of years with the concept of a bifurcated technology, the modular technology, which is what we use nowadays. And a couple of months later, we had an invitation that was cooking for a while by Frank Vieth and his more junior partner, Michael Marin, to do a case in New York. And we came to New York to do that particular case. We brought the device with us in the plane. Times were different, and we were able to do that, and we treat that particular patient. Here's our patient, very sick, obese, oxygen dependent. These are some pictures during surgery where we are discussing what we're doing, and this is the patient next day. Very challenging patient if you treat this patient from the conventional point of view. So I want to take the opportunity to thank Frank here, who has the courage to invite us to come and do this type of procedure for the first time. Was thanks to the support of him and other people around the world that this technique just started. And this was due to the strong collaboration that we had between interventional radiology and vascular surgery. The same type of collaboration we listened this morning that Danny Steinberg was mentioning between interventional cardiology and cardiothoracic surgery that allows these new technologies to move forward. And I was rewarded at the end because together with Parodi, we also developed something for the carotid because he accepted that the carotid was also an important field. And this is the concept of flow reversal. So where are we now, 26 years later, with that technology? Well, in the same way that phones have evolved and the human being have evolved, this technology has evolved thanks to the contribution of people around the world. And some of the people here have made significant contributions in this particular field. We moved to bifurcated technology, then there is a new generation, more durable technology, and of course, the more recent incorporation of fenestrations and branches. So now, probably 80% of the patients with abdominal aortic aneurysms are treated endovascularly. There are 7 devices approved by the FDA. There are still some limitations, of course. We have issues with bad necks, short, angulated, disease, or large necks. And in order to address this issue, some people have come with solutions, like Roy Greenberg came with the idea of fenestration in order to maintain patency of vessels arising next to this complex anatomy. And we here at the Medical University of South Carolina, we were part of that as well, Rena and Flacker, and the group of vascular surgery working together. We were the first to publish our experience with customized fenestrated endografts that we did before the procedure in the back table. And this is the way it works. We deploy the device, we create holes, and then we mark the holes to create those fenestrations. Then you need to repack the device, and then you place it on the patient. This allows you to treat patients with bad or short necks. You can maintain patency to the renal artery, like in this case, and then CT showing good follow-up and patency in these patients. Here another patient with a lower left renal artery treated with a fenestration for that particular vessel. Other groups have work in making branches instead of fenestrations. This is a paper from Gustavo Oderich creating a branch for the internal iliac artery. We had one of the fellows that trained with Gustavo Oderich from Mayo who was working with us, Dr. Garg, and we work in putting together these devices for complex patients. As you can see, this is a patient with an abdominal aortic aneurysm with extension to both iliac arteries, and in order to preserve patency of the internal iliac arteries, we deploy such a device in one side, in the other one, and then we exclude the aneurysm with a conventional device, creating a complete exclusion of the aneurysm with preservation of both internal iliac arteries. Other people, like the people from San Francisco, Tim Shooter, have been working with branches for a while. And of course, we can also do our own branches. These are the branches that we are making at the Med University here together with Josh Adams and the rest of the team to treat patients that are very, very difficult to do with conventional surgery. These branches, once you have them, you can access them from above, or we are using directional sheaths, as you can see here, to get into the branch, and then by using fusion technology, where we import images from CT, we can know exactly where each of those vessels are present, and we can go and put a branch in each of those to obtain complete exclusion of the aneurysm with patency of those vessels. So there are other areas where this technology have made major contributions, like trauma patients, and we take care of these patients with the people from the emergency room. Lesions to the arteries can be done by gunshot, iatrogenic, blunt trauma, and stab wound lesions, and we have been using different type of stents covered with different elements in the last 30 years, from Dacron, from Bain, PTFE, and then different companies have come with different devices, and this is probably a summary of those devices. So whenever you have a patient with carotid trauma, sometimes if the lesion is too proximal, the patient may require thoracotomy. Look at this patient. He has a pseudoaneurysm at the proximal common carotid artery secondary to a gunshot. So instead of opening the chest of this patient to get proximal control, we can use a stent cover stent. This is one of our earlier cases with a balloon expandable stent that we cover with autologous veins of the patient, and you get, as you can see in the bottom, complete exclusion of that pseudoaneurysm using this technology. And we have published this particular work. And then the trauma has been extended to other areas like the thoracic aorta. As we know, treatment of thoracic aorta secondary to trauma has some mortality and morbidity, and we know that endovascular repair has almost replaced open repair in most of the patients. Why? Because mortality is less, morbidity is less, the incidence of paraplegia has come down. Let me share a case with you on a 35-year-old male involving a motor vehicle accident who had multiple lesions, and as you can see in this CT, he has a traumatic lesion of the thoracic aorta. So instead of doing this patient with an open operation, we come from the groin, we do an angiogram, and then we place a device that we control exactly where we want to deploy that device, and once it's in the correct position, that we know we're going to cover the lesion, we deploy the device. This is a 20-minute surgery, minimally invasive, done nowadays percutaneously from the groin with a small sheath to obtain an excellent result. And we have been following these patients, and they do really well. This is such a follow-up CT showing complete coverage with normal appearance of all the vessels. Other fields where we made significant improvements was carotid angioplasty, again, based on Theron's initial observations about the risk of embolization. We learned that we needed to do protection. This was confirmed by Frank and his fellow at the time, Tak Oki. They proved in a surgical model that embolization was universal and the need for protection devices was mandatory. So we have these protection devices that prevent or minimize embolization to the brain, and we have different categories. We have filters, we have distal protection, and then we have proximal protection. Here is an example of filters that are now available. They have different pore size, different tip transitions, and these are some examples of proximal protection device, like the MoMA device and the Gore flow reversal, which is no longer available in the market. And recently, we have the incorporation of a new technology, which is cervical flow reversal, which has proved in a national trial to get one of the best results when you do carotid interventions in terms of very low incidence of distal embolization. What about the carotid stents? Like every other technology has evolved from balloon expandable to self-expandable, and now we are coming with what we call hybrid technology, where we have a self-expandable stent with an open cell that adapts very well to the anatomy of the carotid artery, but it has a net behind a thin layer of 500 micron lattice of PTFE that can protect the brain because the plaque is not going to protrude through those struts and produce late embolization. So this is a new technology that is still under research, and we are part of that research, and lucky enough, in August 2013, we were able to enroll the first patient with this technology. As you can see here, actually this was a patient that Tom Brothers referred to us, and the patient did very well. He recently died. He was very sick for other reasons, but he maintained normal patency of the stent with no problem. And this is a trial that is going on all over the country, and we are 100 cases away of completing the trial. One more area where we have seen dramatic change is patients with stroke. As you know, time is brain. And not only by the use of thrombolytics, but now thromboaspiration and mechanical thrombectomy, we can obtain spectacular results in these patients that otherwise will get a significant deterioration of their neurological status. This patient with an occlusion of the basilar artery was treated by the use of the penumbra technology that aspirates the clot to get complete revascularization of the basilar artery and the branches. And these patients get better on the table when the neuro-IR guys are doing this type of procedures. Here is what you get using this technology. Look at this patient. He comes to the medical university with neurological symptoms, very acute. He has complete occlusion of the middle cerebral artery. And then they go with the thrombectomy or thromboaspiration device that I showed you before, and they get complete revascularization by removing that embolus from the groin in matters of minutes. What about interventional oncology? And this is a field that has grown tremendously, and many of the interventional radiologists are involved in this type of procedures. One of the things that also help is that we are developing new access. And the transradial interventions are now taking place. This was something that we learned from the cardiologists who developed this technology and this type of access, and now we are incorporating for our procedures in our institution. Marcelo Guimaraes is leading this initiative, and we have seen a very important progress and acceptance from the patients when we use this technology. And the other things we are doing are treating more and more patients with extensive tumors in the liver, primary or secondary tumors. And we are using a combination of things. You know, we are getting better technology, so we have image fusion. We can combine intraarterial treatment with radiofrequency ablation that we do through the placement of needles inside the liver next to the tumor or inside the tumor, and then we can treat the tumor with a combination of these type of things. So let me show you a case on a patient that has a single lesion that is sometimes not easy to see on normal CT or non-contrast CT. When we do the arteriogram, you see that lesion showing up very nice on the right lobe, and you see the access picture done at the radial artery on the top. A later phase where you see the splenoportal tree, and you see the lesion actually is 5.3 by 4.8. And when we work from the arm, it's also a good thing because we can protect ourselves better. And these are images that were taken during that procedure. And we do a rotational angiogram and a cone CT with this new technology that we have available at the medical university. And then when we do an angiogram, we can track and get a nice roadmap of where we need to go to be very selective, to be able to embolize that particular area without altering the flow in the normal part of the liver. And then because of this combination with COM-CT, we can guide our needles exactly where we want. In this case, we put 2 needles. Marcelo did it. I don't do this type of things. But he put 2 needles, and then he treated the patient in the table, in the angio table, back to back, after doing endovascular embolization with chemoembolization, and he goes and cooks this tumor with the use of this technology. It's really amazing. We use actually this technology to guide ourselves when we are treating patients with type 2 endoleaks now. Instead of bringing the patient to a scanner and then moving the patient with the catheter in the sac to the angio table, we do everything in one room. So, and this is the result, the follow-up images of that patient. As you can see, there is like a hole in the liver that is the area that corresponded to the tumor, of course, with an area of security that most likely will prevent recurrence. So the endovascular revolution has been amazing. What we have seen in the last 30 years, it's unbelievable. It has been done by the collaboration of multi-specialty, new techniques, new access, new materials. No doubt that the industries have done a tremendous investment, and there has been a transition from open surgery to a less invasive technique. But be aware, not everything can be solved with minimal invasive technique. We still need conventional techniques. We still need good surgeons that are able to treat those particular patients with conventional techniques. And for the young people, I know you may think that we got everything. That's not the case. There is more to come, and don't think like this guy thought in early on, who, despite the fact that he was in the Office of Patents, he said everything that can be invented has been invented. How wrong was this guy? So I think that all of us, we have been witness of it. Amazing times, and there is much more to come. Thank you for your attention.